every tweak we make has some sort of impact, and we need to be as aware as possible of those in general. And then we just need to accept that when we make changes, there's going to be these impacts that we don't entirely understand.
Welcome to Healthcare Liberty Labs with Tiffany Ryder, where we teach you what they don't want you to know about healthcare.
So today we have Brian Reid with us. Brian is a journalist of decades, it seems like. Is that right, Brian?
Journalist is an interesting term. We can get into that. I started my career
can get into that.
I started my career as a journalist. Yeah, I've always been interested in the writing. So I started my career as a journalist, and I write a newsletter now. And there's other stuff that complicates it.
I love it. So I'm really excited to have this conversation. I like to divulge why I'm interested. And with you, it's actually, I ended up on your email list and reading your publication and just found that I always had questions. Like it's one of those emails that I get that I always read through. And I always want to hit reply and be like, yeah, but tell me more about this, or I really liked this, or I hope you talk about that. And so anyway, that's how I actually found you and found your work. And I've been pleasantly surprised. I've been learning a lot. I'll certainly link to the newsletter before we're done so that other people can do the same. But I really just wanted to have you on and talk a little bit more about health policy and healthcare and media influences. And also on the other side, some of the subject matter things that you cover on pricing and, different levers that are being pulled in the pharmaceutical space, because I think that's something that we're all kind of curious about.
All right, let's get into it.
I know, man. Thanks for coming in. So tell me, so I know you are a little more entrepreneurial and on the research and almost like public facing now, but it looks like you started out at Bloomberg. Is that correct?
Long time ago. Yep.
Yeah. Tell us how that works.
No, I mean, my degree was in biology and political science from undergrad. And I decided I was not interested in mortgaging the next 10 years of my life to go to medical school or washing test tubes. So I thought that science journalism was going to be the way to stay engaged in that. And I went to journalism school and ended up at Bloomberg covering the FDA for the better part of 5 years. I did some freelancing after that, but the core of those kind of formative years were very much focused on reading, writing, and reporting. And then I pivoted to PR after about a decade and spent almost 20 years at a PR agency. And in the last 2 years, I launched my own consultancy, and I launched the newsletter Cost Curve, and I got involved with folks at Tough Seaver. So there's a lot of things going on, and it hasn't necessarily been kind of a straight line through journalism. But I think what I've always really been interested in is how do we communicate these really complicated topics, whether it's science, whether it's health policy, in a way that people can do something with that in their everyday life.
Yeah. Yeah, I get there's certainly a need for that. Whether you have a passion for, really talking to policymakers or helping to communicate honestly for big pharma. Pharma gets a bad rap and a bad reputation. We like to trash pharma, but I think that a lot of things that pharmaceutical companies are doing and policy and pricing and all of these things would be a lot more palatable if the public just kind of understood what was happening from that front and sort of what the incentives are along the way. And I think that's certainly something that we need more voices speaking to. What have you found is the area that you most enjoy educating about? Like, do you have a passion for a particular area of this that you enjoy getting into?
I mean, I think I find that the wonky, so there's this nexus between how important is it and how wonky it is. I'm really looking for things that kind of have a high importance and high wonkiness, quotient. because that's really where we have, as you mentioned, like we have a real problem with people not really understanding the way the healthcare system is constructed. So Forbes did a poll 3 or 4 years ago. It was a multiple choice survey, and they said, give me the definition of coinsurance, and they gave 6 different options. Well, it turns out that only 23% of people picked the right option. And you're like, oh my gosh, coinsurance is something that everyone is exposed to in their health benefit design in some way, shape, or form. So it's those places where, there's probably a lot of importance, but low awareness. How can we talk about insurance benefit design? How can we talk about the incentives that are kind of shot through the healthcare system towards, this choice or that choice or this kind of provider or that kind of provider? How can we make that obvious so that we can have a smarter conversation about what the right solutions are? Because I feel like oftentimes we have this policy conversation that's just really based on incomplete information. And not surprisingly, we get a lot of really dumb policy.
In addition to the fact that I am not convinced that policymakers really understand all the ins and outs of what's going on, in addition to that, there's really limited direct influence that we as consumers of drugs and healthcare, as patients, have over that process. And so I think for me, the answer to that question is, well, how do we reach the end user, right? Because the end user, the number of patients that we have in America is obviously larger than the number of healthcare professionals or policy advisors, right? So it's hard. It's hard to figure out, how do I craft a compelling enough message that just a person on the street who is involved in some other area of manufacturing or, is a lawyer and is interested in that thing that they fell in love with and went to school for, how do I get them to pay attention to those topics that are really influencing their life? And it sounds like one way is to find something that's wonky and also important. That seems like a good strategy. But how do you get people to listen? And I'm curious, how you address that question in your own efforts.
Well, I mean, for one, everyone's interested in this, right? I get a letter from my insurance company saying, "Hey, by the way, we're going to raise your rates 10 to 30% next year." And I'm like, "I'm already paying you guys tens of thousands of dollars." And anyone who receives that letter is probably going to ask the same question: why is my premium going up? Because the reasons that were elucidated in the letter were not particularly convincing. Yes, there's kind of tariff churn, but that's not why my health insurance premiums are going up 30% potentially next year. So right there, you have someone who is, I think, hungry for a better understanding of what's going on in the healthcare system. And I think the question is, from a communication standpoint, how do we catch that person right there and start picking 1 or 2 things, that we hope that they'll be engaged in or interested in? And if we can do that, if we can get them kind of engaged and interesting in one piece of it, then the next step is, okay, well, what actions can they take? As you mentioned, we have this incredibly distributed healthcare system. If you are a patient, if you're a consumer, where do you take your complaints? Where is the department with the little box? And oftentimes that's probably your employer, your HR department. They also need to be educated. But there's not this real thought of how do we empower anyone to start having those conversations up the ladder, or even where up the ladder we go.
One of the things that really bothers me about this conversation in general is that I'm not convinced that the system is designed in a way that anyone is incentivized to actually care what the end consumer thinks about, right? So I'll give you an example. You just mentioned that, maybe it's the HR leader or it's the CFO or it's the employer, right? They're certainly incentivized. They're paying tons of money for, hundreds or thousands of people to have access to healthcare. They probably care if their employees are having a horrible experience. But I think it gets harder to influence what's happening the further away those relationships get, if that makes sense, right? So if my CFO is the one who's making the decisions and the HR person is the one who's listening to me, but she has to tell, it's like this game of telephone. By the time it gets to I don't know, the representative at Blue Cross Blue Shield who has, something to do about whatever the complaint is, I'm not sure that it really carries the same punch as, for example, if I'm getting my medication from, I don't know, Eli Lilly direct and the shipment doesn't show up, then I can call Eli Lilly and say, "Hey, dude, I gave you $600 and where's my stuff?" And they probably are incentivized to care very much about that. So it's like the way that, at least, from my bias, when my little area, it seems like our system having so many different players and so much complexity just really makes that communication extremely difficult.
Yeah. I mean, there are three things you just said to pick apart. One is that there's no one in the healthcare system whose job it is to look out for the patient from soup to nuts. I mean, at various points, various people, providers, various parts of the supply chain may have an interest in it, but no one, from the moment you start thinking about a diagnosis to the moment you receive your medicine, you're not having your hand held in the same way that you would if you said, "Hey, I think I'm going to switch to Apple. I think I'm going to get an iPhone." Well, geez, Apple wants to hold your hand from the moment you have that thought until the moment you're in the App Store.
Yes.
So that's one. I think number two, we don't have that in part because the system is intentionally complex. Complexity has been weaponized. Complexity is a barrier to access. There's a great piece last year, the year before, by the KFF guys, Larry Levitt and Drew Altman, that basically say, look, complexity is a barrier unto itself that we need to talk about. And I think the third thing you mentioned that's worth thinking about is like, who within an employer is making the decisions. Are they educated enough? I mean, this is Mark Cuban's big thing. If you are a CFO, you should care a lot about what your overall health spend is. But chances are that's been delegated down. You're confused by the size of the rebate checks versus your overall health spending, and you're making decisions that may not be in the best interest for your company, for your employees, simply because of that complexity. And so you mix all this together, the lack of patient centricity, the complexity, kind of the lack of really understanding where your bread is buttered, and you end up with a system where it's probably not a surprise that we're making trade-offs that we don't entirely understand that lead to outcomes we certainly don't want. But I think everyone agrees on the fundamental problem. I think everyone agrees probably on a lot of the solutions. I think the issue is there is not one massive silver bullet that's going to change everything. It's a lot of these little things. It's a lot of individual actions. Again, the nice thing about Mark Cuban when it comes to drug pricing is he's not focused on this idea that if we can just get 60 senators and the majority of the House and the president to sign something, we're going to see this change. He's very much employers can move the system in a way that's going to be cheaper and more equitable. You don't need the political process. You need the people making the financial decisions to make ones that are going to be more aligned with what they say their values are. And there's something kind of nice about saying, geez, the market can self-correct without necessarily trying to rewire from a regulatory standpoint the whole system. Now, whether or not that's a realistic way of thinking is a debatable point, but it's nice to have this idea out there that, if we all made better choices, we would start incrementally getting closer to the system we want to have.
Well, I think I'm going to have you on like every week because that's exactly the message that I would like to get out. I feel as though this is something that we can do, all the way from if you're the CHRO or you're the CFO and you're making those decisions, but also if you're the consumer and you're deciding, I don't know, where to fill your prescription drug and if you should pay out of pocket for a procedure that is a low-cost preventative care thing. All of these things are options that we actually have that I do think have the potential to move the needle. But I wonder, and I want to pose this question, I have my own thoughts, but do you think that we're in a position where people perhaps have forgotten or lost faith or trust that they actually can make decisions that will have an impact in some way? Do you think
I give people more credit than that. I think it becomes this in some ways it's an informational deficit. In some ways it's complexity set up, to make it more difficult for them. The reality is it's very hard to comparison shop for anything in healthcare. And, that's a failure on a lot of different levels. And I don't want to claim that none of this stuff has policy solutions or regulatory solutions. I think, there's a lot of
Sure.
programs that can operate more efficiently. But I think even if, you are in a doctor's office and you are prescribed a medicine and you want to get the lowest possible price on that, there's a whole decision tree that's required from, is this the right medicine? Could I go to another medicine, or is there going to be a cost associated with that, either to my health or to my wallet? Do I work through my insurance? Do I not work through my insurance? Is there another option? Is there a coup? All of this stuff. No one sits down a high school student and explains this to them. No one sits down a med school student and explains how to counsel a patient through this. So, I don't want to claim this is all about individual responsibility, but we certainly, those are things that we can do now, kind of regardless, to make things a little bit better. And again, that's not to say there aren't larger systemic things that can or should be addressed. That's not to say that there aren't programs that are, not meeting their objectives. But I think, in all of this, there's something reassuring to say that, there are things that can be done on a micro level to get us, make micro steps. Again, I keep saying, if we're going to fix this, it's going to be 1,000 little things, not one silver bullet.
Yeah. And I guess, that is exactly my point, is that I believe that we're making it difficult for patients to where, the average person doesn't even know where to start. I don't even know where to start if my doctor gives me a prescription. I want to be responsible. I want to do the right thing. And what should I even do? Right? I think that's how lost we are. And that's how powerless many people feel.
Yeah, no. And again, it's the complexity being weaponized. So that on the one, it's the complexity being weaponized on the one hand, and I think it's the system and the incentives being out of whack on the other.
Who do you think is doing the weaponizing?
It's really easy to point fingers. I will say that, consumers tend to interact with the system via their health plan, via their insurance company. And so, a lot of what makes it difficult to understand pricing comes from there. And I realize there are systemic issues that flow through the supply chain that are also very important. But if we're talking about who makes it difficult for patients to understand what's going on, whether or not you want to say that there's blame to be assigned here, but I think there's a lot of responsibility that, insurance companies probably have that's not being kind of discharged in the way that's going to maximize patient decision making.
One of the questions that people ask regularly is about pharmaceutical advertising, right?
Yeah.
This is something that comes up a lot. It's something that we obviously do differently here in the States, meaning we allow it, and other countries have prohibitive rules, strict ones on that. How much influence do you think that tends to have on what gets reported by television stations, what people are allowed to write about at the Washington Post or wherever it is? How much influence does that buy pharma?
I don't think it buys pharma in terms of news coverage. The fact that they are a major underwriter of television stations. I don't see a whole lot of evidence that I'm not particularly conspiratorial minded when it comes to the media. Having worked in the media for a decade, I don't see a whole lot of that, influence. I think there's a broader question as to that you're always going to get as to, do we have too much pharmaceutical advertising? What's the appropriate set of regulations? What's the appropriate amount? And I think those are hard questions. Those are a little outside, my wheelhouse. Obviously, we're one of two countries in the world, that does that. And there's always concern about inappropriate prescribing. But usually when people talk about there being too much drug advertising, it's not tied to any sort of impact on patient outcomes. It's just a general sense that this is a poor investment of public health dollars by pharmaceutical companies. And again, if you believe the industry's contention that this is really about disease education, making sure that people are well served, it gets real easy for this to kind of just default to people's priors about what they think about the media or the pharmaceutical industry or whatnot.
Yeah, it's really interesting because it's something that people normally ask in the context of, well, we don't want patients coming in and asking for these really expensive medications, from their prescribers. And I always think, well, I'm going to prescribe what I think is appropriate for my patient, like whether they ask or not. Like, and if they ask, I'm happy to have that conversation with them. But like, I don't feel threatened by the fact that they saw, I don't know, some, advertisement for Ozempic on TV 16 times last night. Like, I'm quite comfortable having that conversation about what's appropriate and what isn't, and why I think they may or may not be a good candidate, and who cares? But that other question is one that I just, I really don't know the answer to. I really don't know if that, has an impact on editorial decisions for what gets covered or what doesn't. But I also haven't written for Bloomberg Health.
No, and yeah, again, my assumption there is the answer is zero. Folks are looking for good stories, and the reality is that there's always going to be a narrative about the dangers of big business, and I think it's hard to say that the pharmaceutical industry has been provided a halo by the media. I don't think the insurance industry has been provided a halo by the media. I think everyone feels pretty unhappy about healthcare. Angry that's an excellent word. And I think the media coverage, reflects that I think, there's certain elements of innovation that get covered, with the appropriate rosy glow. I mean, we are doing incredible things scientifically, as a society. But I think if you look at any other coverage of the healthcare system, it's not very happy, and for good reason. Because I don't, you go around and George Carlin used to have a joke that he would, every time he'd go before an audience, he'd say, "Hey, how's the drinking water in your town?" And people are like, "Oh, it's terrible," everywhere he went. And he said, there's this kind of sense of, everyone had the sense that the water was this indicator of societal decline, and no one thought that the water in their town was as good as it used to be. And you have the same sort of effect if you ask people how their health insurance is. Everyone thinks that the healthcare system is getting worse. That's not fair. I think everyone thinks that their health insurance is getting worse, that the system as a whole is not, dealing well with them. People don't feel that way about their doctors or nurses. But anytime you involve the system, people's hackles go up.
Yeah, that's interesting. I certainly think that healthcare seems to be harder to access. Seems like 10 years ago, I could call and get a primary care doctor easier than I can get a primary care doctor now, just to establish care or, but I don't know. That's interesting. I do find that for sure with comparing it to other countries. And as someone like I've traveled a lot and I've lived overseas. And so it's always funny when people are like, "Oh, well, the healthcare system here sucks, but it's great in the UK." I'm like, have you been to the UK? It's actually not great.
It really does come down to these sets of trade-offs. And we don't talk in the United States very often about trade-offs. We have our trade-off is we have an incredibly expensive system. And people like to talk about, pharmaceuticals. But the reality is appendectomies are a lot more expensive here. And cesarean sections are a lot more expensive here. And you just go through the list. And in some ways, we're doing this on purpose. And what we get in return for these high prices is we have excellent choice, right? You can choose your insurance company, you can choose your doctor, you can choose all of this stuff. Like, I pay an astronomical amount for insurance because I'm picking the option that's giving me the most choice of providers. And there's a huge financial cost to me, and it's worth it. I think. And in other countries, they have a less expensive system, but they have worse access. They have fewer choices. And I think oftentimes we forget that that's the fundamental tension here is, can we have cheaper healthcare in the United States? Yes. Are Americans willing to sacrifice choice? Are they willing to sacrifice access? That's a debate that we can have. That again, this is not a right, wrong, right, left ideological thing. It's a question of, where do you move that slider? Are we at the point now where healthcare is so expensive that we need to pull the choice and access slider back in the other direction? There's not a right answer to that. That's the debate we should have, as opposed to this idea that, again, there's some sort of magic thing that's going to give us choice, access, lower prices, all of these magical things without making a compromise.
So I like the framing of that, because I think that those are the loops that we get into, right? We get into these loops where, someone says, oh, we need a single payer system, but they don't recognize that a single payer system comes with these 10,000 negatives. Or they say, oh, we need to do, this other solution. And it's like, yeah, but also all of these things. And when you look at it, and you've said it like 4 times now, and I think it is becoming the theme of our episode, right? But when you look at it, instead of like, what's the one solution I can put here and force everyone into, as opposed to, well, are there 3,000 different, parts of the equation that I can really adjust and get, marginal improvements across all of them, and then end up with a system that, functions better and is more affordable and more available for more people? And I believe the answer to that is yes. I talk to a lot of entrepreneurs, and I see people trying new things and new systems and new forms of interacting and offering access to medical services, to prescriptions, to whatever, all the time. And I just think that there has to be a way to adjust these to make things better.
And there are, but again, at the end of the day, there's just keeping that idea of trade-offs, I think, ever forward in our mind, that yes, can we get better prices? Absolutely. Where's the trade-off? Is the trade-off that, we can get better prices, but that hospital's going to close? Is that worth the trade-off? In some cases it may be, in some cases it may not. If we hamper prescription drug innovation, we're going to get fewer cures in the future. If we amp up, pharmaceutical investment, that's going to mean more money out of the system, but maybe we'll get more innovation. We'll get more cures in the future. What's the appropriate number of medicines we want to see approved every year? We have an ability as a society to dictate that number. But that again is going to require trade-offs, and that trade-off is very often money.
Yeah, it's really, really interesting when you start getting into it. I don't know if you saw this story, but there was a study that was published. Man, now I wish I had all the details on hand. All right. So the story was, look, most medical research that we've done. So you go through, you take 20 patients and you put them through this regimen, and then you see what happens. And then you say, oh, this drug worked well or didn't. Like most just normal pharmaceutical research studies, after they've done whatever the requisite is and they've gotten their FDA approval, they're never repeated. And this is something that people are just talking about in academia and what have you. They're like, oh, they're not repeated. These results, when the study is repeated, the results are not the same. We need to have more studies being done to validate prior studies, right? And the response to that is, okay, sure, that's great. How many studies? Is it 5 studies? Is it 100 studies? Can we afford to do every study for every drug 800 times? Yes, if we decide not to eat. What does that equation look like? And it almost seems like that's the piece that gets missed in a lot of these discussions and a lot of, this reporting. Like, would I like the drug that, I don't know, I'm going to take 20 years from now to have been studied 800 times? Oh, yes, I would. But am I willing to pay for that for every drug that everyone's taking? No, I am not. And so there is some degree of risk in all of these decisions. and there's a cost to what makes us feel safe and secure, which I'm not even convinced actually is safety or security.
I think you've got it right. There's a slider here, and where are we going to sacrifice money for innovation? Where are we not? And then I think to your point, there's a whole lot of people who are trying to find better mousetraps. We are essentially running the same clinical trial system that we've had in place for a century. This is not, what's going on in the labs now. And I don't want to dismiss the scale of the technology here and the absolutely incredible biologic breakthroughs we're having. But at the end of the day, we've got, this idea of a controlled clinical trial. That goes back to, experiments on British soldiers in scurvy, from hundreds of years ago. That's still the basic framework, and it's worked really well. But I think the question is, are there innovations that can get, that can get us better answers more cheaply? But again, what are we trading off there? Is there a standard of, are we willing to have lower evidentiary standards? So again, we keep getting back to this idea that, like, what are we willing to trade off for more innovation, cheaper healthcare, more choice? None of this stuff. That there's no tooth fairy.
Yeah, unfortunately. Dr. Drew Pinsky. I used to watch Loveline when I was in high school, and he would always say, "There's no free lunches."
There are no free lunches, but almost entirely the debate about healthcare in this country is predicated on this idea that if we just did X, Y, or Z, we could have more for less, and that's not really the way life works. And every once in a while, there's some sort of efficiency or breakthrough or
Sure.
way of going about things that changes that. But in general, I think we have to accept that. What are we willing to trade off, and can we be honest about those trade-offs?
Yeah. Well, I promised you that I would ask you about 340B, which is gotta be the worst marketing of anything, because it doesn't say anything, it doesn't mean anything. We read about it in the newspapers. Most of us just skip on by because we don't understand it. So tell me what 340B is.
Oh, I was hoping you weren't going to bring it up, because you start talking about 340B and the lights just go out of people's eyes. Poof.
I waited until they liked you. That was the best I could do.
I mean, it's one of those things that the reason people call it 340B is that's a reference to where this language appears in the federal code, and we don't have a good slang for it because it was established as a very small program that wasn't supposed to gobble up the entire healthcare system or really anyone's attention. Back in the early 90s, when the Medicaid drug program was established, the rules made it very difficult for pharmaceutical companies to offer discounted drugs to hospitals. And so as this kind of fix, this 340B rule that said, look, we're going to set a very cheap price that pharma companies can give to very select hospitals so that they can get these cheaper drugs that they can then use, to improve the care of their vulnerable populations. The problem is that that program started with a very small, targeted, intention. And since 1992, it's gotten enormous. And so there's really three things about 340B that I try to explain to people before they turn around and just walk away from me. The first is that this is a program that is enormous. It did $66 billion in sales. So there were more sales under 340B than there were in the Medicaid drug rebate program. It's growing at 20% a year. It's a lot of money, and hospitals are generating somewhere in the neighborhood of $60 billion in profits every year. So the first thing to understand is this is a really enormous program. The second thing is kind of how it works. Like with the way you describe it's like, okay, drug companies give select hospitals really cheap drugs. And if you just stop there, people assume that those hospitals turn around and give those cheap drugs to the vulnerable patients who need cheap drugs.
That was literally the assumption I was just making as I was sort of going through this $60 million. I was like, 60 million, 60 billion?
Yes. So it's like, well, how did they make $60 million on a program that they just get cheap drugs?
Where you're just funneling free drugs or cheap drugs. You should just,
hey, here's a drug that I received literally for a penny. Why don't I just give it to this person who doesn't have insurance?
Okay.
As it turns out, it's much more profitable for a hospital to take that medicine that they receive at a very low price, give it to someone like me, who again is paying tens of thousands of dollars in health insurance, bill my health insurance company and keep the difference. And then, if you're a hospital, you say, I can use that however I want. I can use that to assist vulnerable populations. I can use that in almost any way I wish. And as a hospital executive, I know how to use that money to benefit the community the most. Which brings kind of the third point, which is there's zero oversight. So hospitals receive this spread. There's this weird arbitrage. They buy low, they sell high, they have all this money in the middle. But then there's no one who says, geez, you're using that money wisely, you're using that money poorly. There's just $60 billion, give or take, just flows into the hospital system in a way that is virtually untraceable. And so you can try to look for evidence. Do 340B hospitals provide more charity care? Not really. Do 340B hospitals work with pharmacies in lower income areas? Well, not really. Do 340B hospitals open up child sites in more vulnerable areas? No, not really. So it's very hard to find any evidence that this is benefiting the community because there's just zero oversight. So those are really kind of the three basic things to understand. It's a really giant program. It works in this really weird way, and there's really not a lot of evidence that it's necessarily helping the people you would think it was helping. And so once you kind of lay that out, you can start asking, why is it? How can we change that? And who's really benefiting and who's not? But really, at the end of the day, that's why the program is worth talking about, even though it is in horrible need of some sort of rebrand.
So that's why it's in my news feed on a daily basis.
I'm kind of obsessed with it, and there's always something interesting there. The problem is it's just so hard to get people to the point where they can start grappling with this because none of this is intuitive. This idea that, this small program from 30 years ago is suddenly this dollar-eating monster that no one understands how it works. Again, it's very easy to just turn around and walk out in the cornfields and never come back after talking about 340B.
Yeah. Well, I have so many questions. I'm trying to decide which ones other people are also going to have questions on. I guess my first one is, who's losing? Who's losing here? Is Pfizer selling the hospital a drug for 10 cents that they would charge another hospital $3? How much is it? Are they losing money on the 10 cents? Or should they have been selling all the drugs for that much? Who's losing?
Certainly the manufacturers are losing. Or put another way, the manufacturers aren't getting what they think that they probably should be getting out of this program. So if you're going to dump $60 billion of inexpensive drug into the system, you would really like to see a world in which no one is going to go without your drug for lack of ability to pay. I think that the industry would probably be more than happy to invest what they invest in 340B if it was truly knitting together the safety net in a way that was more compelling.
Well, and this is my second question. Are the people who need the safety net being charged 10 cents for the vial of insulin, or are they also getting upcharged? Is the uninsured patient who 340B was actually intended for going home with a big fat bill that includes whatever this pharma product is?
By and large, the discounts in 340B do not follow the patient.
Okay, regardless of coverage.
Yeah, and this is not universally true. There are ways that you can in some certain select circumstances.
There are no universal truths.
And I think everyone feels like, that's a win for patients and for 340B. But by and large, the way it works is a hospital buys a medicine, that retails for $50. They buy it for $10. The insurance company reimburses it $60, and the hospital has $40, $50 per script that they can, again, maybe they're investing that in the community, but they have zero obligation to tell anyone where that money goes.
Okay, so whatever this legislation is doesn't mandate that for the uninsured patient, it's passed on to them. They can charge the uninsured patient $50-$60 as well.
They could. So it's so I think that's where that's where people's, wheels start turning. Do we need more, the first question is always, do we need more transparency? Do we need a sense of where do these dollars go? And I think you've seen a lot more states moving in that direction from a state regulatory standpoint. Are we incentivizing the right hospitals here, or is the program, too big? Because there are hospitals that probably legitimately see this as the difference between success and failure as an institution, and no one designed the program that way. But it's also hard to say, oh, we're going to pull the plug on this whole thing and accept that vast swaths of the hospital market are suddenly going to be in the red. On the flip side, there are a lot of 340B hospitals that are doing just fine, and they have a large portfolio of investments in tax havens in the Caribbean. And are those the people that really, they could stand to have some more accountability on their 340B dollars?
Yeah, no doubt. I've always worked in rural hospitals. I've never worked in these bigger cash cow hospitals, but there is limited transparency, right? That's what I believe to be true, but I don't actually know what's true. I don't actually know the fiscal standing of the hospitals I've worked at. They could, very well be telling us a line like they tell the public, like, "Hey, we've got a bill at maximal capacity because you don't want this hospital to close," and no one knows.
Well, I mean, and that's what becomes hard, because it's hard to say that everyone is kind of crying poverty and they're all telling the truth, and it's very hard to believe that they're all lying as well. And the problem
Yes.
is, any changes, and we saw this with the discussion about the tax and Medicaid bill. Any discussion of changing the finances of hospitals is going to create this sense of like, oh, are we imperiling certain hospitals? And at this point, I think the answer is kind of vaguely yes, but it's very, very hard to quantify.
One of the things I like about your newsletter is that it doesn't really seem to have any strong bias that I can sniff out. I have a lot of trouble when I'm, reading through my news feed, and that certain publications, it doesn't matter what, the HHS secretary says. It's always bad as reported by, right, a certain publication, or whatever changes are being proposed by, I don't know, someone else that they have decided is the devil, is always bad. And what I really enjoy about, I can't even think of the name of it right now,
Cost
your
curve.
publication. Yeah, Cost Curve. I knew it was two C's. It comes in my inbox every day, and I sort through the headlines more than anything. But what I really enjoy about reading it is that it gives me a different perspective than I really get anywhere else. How is it that you've been able to maintain that? Is that one of the reasons that you sort of went out on your own to do this consulting so that you could say what you wanted, or how does that journalistic process work for you?
Yeah, so let me help you out a little bit. I am not free of bias. I would say that Cost Curve reflects my general, and it's weird to think of this as being a particularly ideologically driven position, but I tend to be pro innovation. I think that we as a society should probably spend more money on more research, more medicines, and that it is incumbent upon us as a society to find the places of less value to create the space for more spending, more investment in innovation. And that's a position. I'm willing to say that as a society, we need to make trade-offs in order to get certain things. So we know that obesity medicines are cost effective. We know that the price is going down. We know that they are being used in more and more areas of really great medical need. We also know that for every eligible patient to get them, it's going to be an absolute budget buster across the board. And we should be having a serious conversation about whether or not there's low value care we can get rid of, whether or not there are other societal priorities that we need to sacrifice to get people access to these really wonderful medicines. But my bias is going to be towards We've got great tools. Let's figure out how to use them. And that's, that's a bias there. You can certainly have a bias to say we have a finite amount of resources in this country, and we need to be really super thoughtful about how we use our health resources. And we're not, and therefore we need to accept that there's going to be less innovation, or we need to accept that there's going to be, more stringent government control. So I've got, I run a consultancy. I work with industry. I am certainly not pure. But I do, I do want to make sure that I'm coming to things with at least a sense of ideological consistency, and also accepting that as long as I have no problem with people on the, who have different views, as long as they accept that there's a certain degree of trade-off. And I try to accept that on my own behalf as well. That look, if we want endless spending on obesity drugs, well, you know what? That might mean fewer roads, less cops, less aircraft carriers, less infrastructure. Those are hard sacrifices to have to talk about. But if we're not willing to talk about it, then we're not really having a meaningful discussion.
It's so true. It's so true. Informed consent is something that I just can't shut up about. And it's really just that. Right? Like everybody thinks informed consent is some legal paperwork you sign at the doctor's office, but really it's about I don't know. You brought up the obesity medicine drugs, and I think it's just a great example. Like this is such a great tool. And I have seen such amazing transformations in patients' lives that I honestly, in earnest, believe will result in them living 10, 20 years longer than they would have otherwise. That all of that said, do I think that we know that these GLP agonists are completely safe medications that aren't going to have something crazy happen, like happened with, Vioxx or other drugs, 5 or 10 years from now? I have no idea. But I think that all of that is okay. And that's not my decision to make for my patients. It's just to say, we don't know what we don't know. Here's what we do know. And how should we go forward, right? And I think that's okay.
I mean, that's the honest way of looking at things, and everyone's got to make those. Again, there's always going to be trade-offs, and I think the problem with so much of the dialogue around health and medicine, around health policy, is this idea that there's some sort of magic bullet that's not going to have a trade-off. Yep. And if everyone just put their priors, just kind of put their assumptions on the ground when we started, we'd probably be in a much better place. If someone said, I am perfectly okay with the government aggressively, negotiating drug pricing, and I accept that we're going to get 20% fewer medicines every year. That's an intellectually defensible position. Saying, oh, we're going to do this and there's not going to be a single impact anywhere else in the system is just not intellectually honest.
Yeah, it's totally true. And I think no matter who's in power, left, right, whatever, a lot of the story that we end up hearing is all we have to do is this and everything's going to be wonderful, which is, like you stated, it's never quite that simple.
We have decades of evidence showing that is not the case. That every
entire universe
we have done to make life better has had unintended consequences, and maybe the trade-off has been worth it. The way I am insured today, I would have been impossible to have done as a self-employed person 20 years ago. That's fantastic. We have a whole different regime now with other trade-offs. And again, this was not a magic bullet. Healthcare prices have not been, exactly trending in a way that's reasonable, over time. Every tweak we make has some sort of impact, and we need to be as aware as possible of those in general. And then we just need to accept that when we make changes, there's going to be these impacts that we don't entirely understand.
Well, tell us a little bit, before we go, just tell us a little bit about what you're doing in your business, what you're looking forward to writing about so that I get a preview for what's going to be in my inbox.
Sure. Well, I mean, I think we're in a really interesting policy environment. So I'm excited. I've got the consultancy. I talk a lot about policy. I'm working, I'm speaking, I'm doing all that. But it's that processing every day, that writing, that I'm really enjoying, because it allows me to explore stuff that, I don't wouldn't otherwise necessarily get to have my hands super dirty in. I think this farm to table idea, this going directly selling medicines to consumers, is a hugely interesting trend, and I'm really curious
so
where
cool.
that goes. Both from kind of the pharmaceutical companies that are pushing it, as well as the telehealth companies that started very narrow, and they think that they've got a way of really owning that patient relationship. That's fascinating. Obviously, I'm going to keep paying attention to 340B. The other thing that I'm finding really fascinating is what's going to happen to pharmacies. That's been a really hard business to be in. And it's weird because I think of, I'm old enough that I think of pharmacists as kind of, in every town you had a carpenter and a dentist and and an insurance broker and a pharmacist, and they're all part of the fabric of this community. And this idea that retail pharmacy has a place in 2025 is suddenly a debatable proposition. And again, not saying that the status quo is where it needs to be, or that going back to Brian's childhood in a small town in 1985 is where we need to be. But we're seeing the reshaping relatively rapidly of, I think, what has been a cornerstone of American healthcare for a long time. And I think we're at a point where if anyone told me that they have a vision for what retail pharmacy is going to look like in 5 years, I'm not sure I'd believe them. So seeing the evolution there is going to be really interesting because, again, this was a core part of the community of the healthcare system, the patient-facing healthcare system. And what's going to happen next? Good question.
It really is. On that note, something that I'm seeing, and I'm curious to read about it if you choose to write about it, but this whole emergence of consulting pharmacists. So, we have independent pharmacies that are struggling to stay open, and there's this whole network of pharmacists who have sort of opted out of the retail pharmacy, working at, CVS, Walgreens, that type of environment, where they're not having a chance to do as much patient-facing stuff, the sitting down and talking with someone about what they're feeling like on their medications and what questions they might want to ask their healthcare provider. That, I don't know, I assume 1920s relationship with your pharmacist. There are quite a few pharmacists in my network who are launching these businesses where they say, oh, you have a child with autism or who's on a lot of medications. Well, we have this subscription-based consultancy where we can look through your prescriptions and help you with de-prescribing and all of these things. And it's just, I think it's exciting because I agree. It is just changing so fast and is just not sustainable the way that it is due to cost and losing of staff and, wait times and unavailability of drugs and all of these things. But it seems like, we're not even to the crashing point yet. And there is innovation that's happening. And there are people who are hopeful and solving these problems in real time and coming up with this new paradigms. It's really interesting.
We're definitely in the thousand flowers blooming, right now. And I think there's going to be a lot of, and that doesn't mean there's not going to be a lot of pain, but you see people experimenting with cash plus models. You see pharmacies, quite frankly, that are being backed by 340B entities popping into places where other retail pharmacies have gone out. I think the whole idea of direct primary care, which is, I think, is an extension of the idea you just talked about. All of that is again, which of these experiments is going to prove to be successful? No idea.
Probably multiple of them would be my guess.
I hope that there's a multiple different ways of getting to goal. I mean, and maybe there will, and maybe there won't. But I think this is a place where spending a lot of time and attention is not a bad idea because, again, we're never going to live in a world in which you're not going to need that intermediary between in front of the patient when it comes to medications. How does that, what does that look like?
And as a clinician, I need to know. I need a pharmacist I can talk to and say, Epic is yelling at me about this crazy adverse effect. Is this real? I just it'll be interesting to watch as the landscape changes. So tell us how to sign up for your newsletter.
So you can sign up at my website. So my consultancy's website is reidstrategic.com. You can just Google cost curve Brian Reid and you'll probably find it as well. Certainly, hopefully I am the top search for Brian Reid on LinkedIn. So spend a lot of time there. I hope so.
And it'll be in these show notes too, because I've genuinely enjoyed it and just to really appreciate you taking the time to come on and chat about all things 340B and others.
Well, this was fun. So thanks for having me.
This has been the Healthcare Liberty Lab. Thank you to our listeners and our sponsor, Crowd Health, for making this possible. Be sure to subscribe wherever you listen to your podcast, be it Substack, YouTube, Spotify, Apple, or somewhere else. We're glad to have you with us on this mission to rethink healthcare together.